Welcome, everyone. Thank you so much for joining us today. This is the second of a series of webinars in regards to the COVID-19 pandemic and epidemiology, showing how epidemiologists have tackled this pandemic, how they're contributing to the efforts to address the pandemic. And today we have the honor of hearing from Dr. Travis Gayles. He's the Health Officer and Chief of Public Health Services in Montgomery County, Maryland, Department of Health. He is the former Chief Medical Officer of the DC Departments of Health, HIV/AIDS, Hepatitis, Sexually Transmitted Diseases, and Tuberculosis Administration, and Chief to the Division of STD-TB Control. So as you can see that he's had some experience, not only in Montgomery County, but prior to that in regards to infectious disease. Joining him today is the senior epidemiologist, Dr. Chunfu Liu, who is working also with Montgomery County Department of Health and Human Services. He has more than 2 decades of experience in public health and currently is serving, as I mentioned, as the chief epidemiologist with Montgomery County Department of Health. He leads a team of researchers, epidemiologists, biostatisticians to support public health functions. And we're very grateful that our students have had an opportunity not only to work with them as interns, but also even to get employment working with Montgomery County Department of Health and working on these various issues. So with that, I wanted to remind you to please keep yourself on mute unless you're speaking. That way it will really help with the feedback. If you have any questions, you can post them in the chat box. But Dr. Gayles and Dr. Liu, we're going to double check with you. Is it okay if we hold those questions until the end of the presentation?
Yes.
Great. Okay, we'll do that. I think that will make it a whole lot easier because we are also taping this just in case students and others are unable to participate at this particular time. I also want to take the opportunity to remind you that this Friday we're going to have an additional webinar with our chair. Dr. Chunfu Liu is going to be talking about the work that he's been doing and modeling this pandemic. So with that, welcome Dr. Gayles and Dr. Liu. Thank you so much for joining us virtually at a safe physical distance and sharing your lessons learned as we've been engaged in efforts to address this pandemic. We are going to have a short message from our dean, who unfortunately was unable to join us today, but he did want to issue a formal welcome for the seminar series.
Hi, I'm Dean Boris Lushniak, and welcome to the special seminar series on the epidemiology COVID-19. This is an incredible moment in history for us to be tackling the pandemic of COVID-19. And what a great opportunity for us to be able to work together and to educate each other on the pathways ahead. First of all, thank you much to the organizers of this seminar series and for having this forum for us to be able to exchange ideas. Over the next few days, you'll be listening to experts in the field who want to have an interchange with you, an exchange of ideas with you through the webinar that we're presenting now. In the next few days, you'll be hearing from Dr. Olivia Carter-Pokris, part of our faculty here at the University of Maryland. You'll also be hearing from Dr. Travis Gayles and Chunfu Liu from the Montgomery County Department of Health, who are out there in the front lines of public health action against COVID-19. And then finally, you'll hear from our esteemed chair of the department, Dr. Hongji Liu. So this combination is not just about that foursome presenting to you, but it's the interchange of ideas in the midst of a public health crisis. We learn from each other. So let's utilize the seminar series to get better at what we're doing. Thank you very much for attending this, and let's learn together.
At this time, I'd like to turn it over to our guest speakers so they can share their lessons learned from their work on the front lines in addressing this pandemic.
Good afternoon, everyone, and thank you for the opportunity to share with you some of what we've experienced and also hear from you in terms of what your experience has been like in the last 2.5 months or so. We've often I've used this line a lot, is there is no playbook for any of what we have been doing, and we've continued to learn and utilize and execute the best practices that we have learned through our public health training and our clinical practice, as well as leverage partnerships, including those working closely with faculty at the University of Maryland to help guide us in terms of our next steps and how we proceed. Now, I remember back in January when we first received word that there were cases of this coronavirus thing in China, somewhere in Wuhan, and we attempted to draft information, a frequently asked questions memo for our employees, our county employees, to alleviate any anxiety. At that time, it wasn't clear that we would be impacted, although we suspected that at some point we would see cases pop up in the United States. Now, for those of us in the public health world, again, the idea of an outbreak or an epidemic or even a pandemic are things that we have studied, we've read about. We've even participated in a number of exercises as well as real life experiences impacted by those particular things. So this was not news to us and it was not alarming. But what was interesting is that in the context of having these discussions, we had to have some frank conversations about, well, what does this look like considering many of the support mechanisms for public health have been cut in terms of funding and support over the last 3 to 4 years, including an Office of Pandemic Services, including funding to support a significant number of our sexual health services that do provide a host of our contact tracing, our traditional contact tracing in the public health departments. And as you know, contact tracing has become the new sexy term that everyone wants to talk about and be considered an expert on. We also know that this has happened in the context of significant issues in terms of overall funding for public health enterprises in terms of how we deliver services to our residents. And so I say all that to say that as time marched on, we continue to look at how do we respond to this from an anticipation method, thinking that it's probably not going to be too big, too significant. Do we have enough testing capacity? Who are we testing? What is that criteria? And as we continue to find out more information, we did do, at least from the Montgomery County perspective, we did engage our county departments across the board, including our school system, our Department of Human Resources, transportation, housing, planning, recreation, et cetera, as well as our elected officials. We had I remember doing a council briefing on Tuesday, March 2nd, where we laid out all of the different steps that we had done to engage our organizations to prepare when cases would come. Little did we know on that Tuesday that 2 days later, on March 5th, I won't forget this because I got the call at about 6:15 on that Thursday evening. Hi, Dr. Gayles. Congratulations, you have the first 3 cases of COVID-19 in Maryland. Can we do some interviews to talk to you about it? So even in our best efforts to prepare for the advent of cases, we knew that we still had a significant amount of growth, a significant amount of planning, because we didn't have a lot of information at that time. As some of you may recall, testing at that point was very limited. In the context of the only place doing testing was the Center for Disease Control. In order for an individual to get a test, they had to meet the criteria, which at that time was heavily tied to travel history specific to China and specific to the Wuhan area. If individuals were screened and met the criteria, through calling the local health department and talking through the state, we then got a test that we sent to Atlanta for review. Now, that was the case for a number of weeks, particularly early on in the number of cases. And at that time, in fact, all of our cases and early cases within our jurisdiction were tied to travel history. And so, again, the screening criteria limited to travel history. At the time, it was also limited to individuals who were demonstrating symptoms, because the data at that point suggested that the only folks who transmit the virus were individuals who were symptomatic, that asymptomatic transmission did not exist. So we continued to move through this journey. At that time, continuing to try to do contact tracing on our early cases, to again try to provide advice. And I think now in the context of we are at a little bit over 5,400 cases and over 27,000 cases in the state. Those early stages 2 months ago when we were talking about single-digit numbers. As that time has evolved, our response has had to grow and be nimble and respond to new data. That has included changes in the test criteria, changes in the test availability. To give you context, not only the testing being limited to one place at CDC, even as it expanded to allow for state public health labs to test, there was still limited capacity. I don't have the manila envelope in front of me in my office right now, but to give you a sense of how things worked is I received a manila envelope with 30 test kits from the state and said, here are test kits to go out and test folks who need, particularly those in nursing homes, potentially who demonstrate symptoms. And so that has evolved. We now have private laboratories involved. Still, there are significant issues with access. So in order to get a test in many places, you have to have a provider provide you with a referral. You can imagine that those who don't have access to a primary care provider or a meaningful relationship with some type of medical enterprise are continuing to be locked out of that system. And so we continue to explore and develop strategies to be able to respond to those needs to make sure all individuals who need tests, regardless of their insurance status and ability to pay, have access to those types of resources. And on our end, we've created a number of alternative testing strategies, including alternative test sites through our vehicle emissions program, the Wheaton Recreational Center, and those two places are significant because they are located in and are adjacent to the 3 high volume zip codes within Montgomery County who have the highest number of cases, 20902, 20904, and 20906. And again, recognizing that we still have to improve that, we are creating a hotline that individuals can call in, and that will go live next week. So that if you don't have a provider, you can call in and talk to a provider, get screened and triaged, and referred to one of the testing sites. Now, again, we recognize that that still has limitations, and so we are in the final stages of standing up a mobile testing apparatus that will be able to do ready and rapid response to different locations to be able to provide testing services across the geography of our county. We've also implemented another strategy that fits within this category, a rapid response team in partnership with the state. Rapid response teams have been tasked with working with different segments of the population considered to be high risk. We have one team working very closely with our Services to End and Prevent Homelessness team, and another team that's working with a number of community agencies who've identified families who are in acute crisis. And we link those teams to provide testing to those families in place, as well as help address their social support needs that are making it difficult to isolate and quarantine at home and have successful outcomes. So that's just one aspect of that, and testing continues to evolve. We continue to look at ways in terms of how we can test asymptomatic individuals within our society so that we have a better understanding of what the true denominator is for COVID-19 cases within our jurisdiction and across the state. We'll be announcing some pretty significant things in that area in the near future. So testing continues to be a big issue that we work in. Also, as time has evolved, we have seen the impact on certain geographic areas as well as certain communities. I believe you had a presentation on Monday that talked about the impact of COVID-19 on the Latino community. And we know that numbers show across the country that COVID-19 has disproportionately impacted traditionally minority communities. In particular here, as it relates to cases in Montgomery County, we're still working to be able to get more complete data for racial and ethnic categories for COVID-19 cases, but we do see some significant issues when it comes to death. By rate, African Americans in Montgomery County, the fatality rate is 41.9 deaths per 100,000 residents. Followed, Dr. Liu has the numbers, and that is a significant difference in comparison to other groups. So we continue to look at how we can respond and understand what factors and variables are driving those particular disparities in outcomes. We know that historically, that health disparities didn't just start when we talk about COVID-19. They have persisted within our society for decades. And we have a pretty good understanding and belief that, particularly when we talk about the impact of underlying health conditions on, if you have COVID-19, being predisposed to worse outcomes if you have underlying medical conditions. The data clearly shows, and as we've demonstrated at least in the last couple of years. In a number of reports, we've demonstrated that communities of color are disproportionately impacted by those very same conditions that we know predispose you to having worse outcomes. And so we hope that in this time and space that we continue to look at how we link social determinants of health to outcomes and make sure that we are not only addressing those immediate needs from that perspective, but having a meaningful conversation to look at the impact of those social determinants on outcomes in this situation, because God forbid we have a COVID-26 or a COVID-35 or some other situation where we're talking about how those same disparities that have been with us for many, many years are continuing to manifest in disproportionate outcomes related to a particular pandemic. One of the other things, I'm just checking through the list here, one of the other big areas that we have worked in terms of testing capacity and research and data is also how do we respond nimbly and flexibly in terms of providing acute care services. So we've talked a lot about surge capacity and bending the curve and peaks. We have worked very closely with our hospital partners, again, before we had cases in our jurisdiction and continuing through that process to make sure that we have the adequate supplies and equipment to be able to provide services for individuals who need hospitalization. So yes, we have seen an increase in cases as that moves forward. And quite frankly, as we expand our testing capacity and hopefully capture more individuals who otherwise would have been missed because either they don't have access or they're asymptomatic carriers, we know that those numbers are going to go up. But we also watch, and this is why it's great to have partnerships with institutions like University of Maryland to help guide that process in terms of other metrics, including hospitalization rates, bed capacity, ICU capacity, looking at our models to help us determine where we're going in terms of our future peaks and to help us plan better. And so that's also a big significant component of what we've been doing. I'm happy to say, knock on wood at this point, our hospitals and health systems have been able to meet the needs of our residents who have required hospitalization, both for COVID-19 as well as other illnesses during this time, and we continue to monitor that. We work very closely with our peers and colleagues throughout the state of Maryland, as well as throughout the National Capital Region, with our partners in DC, as well as Northern Virginia. And it's very clear, and hopefully very clear to those at home, and I know the governor is actually having a press conference right now, and I believe is laying out some of that criteria from a commerce perspective in terms of how we will reopen. We all remain committed to leveraging science and data and clinical evidence to guide those conversations and discussions as much as possible so that whatever decisions are made in terms of furthering our economy and opening up society, we know that they are guided by the principles of public health to maintain and maximize the safety of our residents. In the interest of time, I will stop there and turn the floor over to Dr. Liu, but we'll be happy to answer any questions that you have about anything that I've discussed or any other questions that you're curious to find out about and how you build a rapid response. Thank you.
Okay, thank you, Dr. Gayles. Since Dr. Gayles covered the overall higher level of the operation and the preparedness of the response to the COVID-19 in Montgomery County, I'm going to focus on pretty much on the surveillance and the data piece of the response to the COVID-19. So I'm going to cover the areas on the confirmed cases, hospitalization and ER visit, and mortality, healthcare capacity forecast, and the fancy term that Dr. Gayles has been mentioning that is very popular these days about the contact tracing, and then the nursing homes. So it's a complicated process of how we consolidate the cases pretty much every day. And most of these cases, actually, they are laboratory confirmed cases. And we have a system used by the state and each of the jurisdiction called the NETS, National Electronic Disease Surveillance System. It's a little bit like an antique data system. It was used for surveillance of the common reportable and communicable disease. But since the occurrence of the COVID-19 happened all of a sudden, that this one was used in the national level and in the state to report those cases. And then particularly, this system is used by private and then public laboratory to confirm cases and then tracking the test result. And then the other data source that we receive from the state infectious disease bureau is called the REDCap, and it's a combination of the different of the cases from various data sources. And the other source of the data we receive are we call it the paper lab, and those are the laboratory reporting to us through the fax or the hard copy document, not through the NAS. So we also capture cases from this mechanism. And we also got that information, very small percentage from the medical examiners, because it confirmed the death due to the COVID-19. And then we will also cross-check to see if this case also has been confirmed previously. And then because we are neighboring to other jurisdictions like DC, Prince George's County, and other counties, we also get reported from neighboring counties. So these are just some examples charts that we have been using to monitor the increased number of the cases daily and cumulatively. So these are not the most updated one. And for example, this chart on the left-hand up corner, this one shows the daily count and cumulative count for the residents in Montgomery County. And we also look at the doubling time, which is many organizations feel this is a good indicators. As of like yesterday and today, for Montgomery County, the doubling time for the confirmed cases is about 14, 15 days. But we have been monitoring the trend over time since the very beginning. And then it goes from previously from like 7 days, 6 days, 8 days, and then right now we are in the 14, 15 days. And then the chart at the bottom is the percent positive of the test result. And then this is in the state level, not in the county level, that we have a difficulty getting such information for the county level. And then there are these two maps over here. Recently, they were created. And then because of the huge number of the increase of the cases every day, we look at the 5-day increase of the number and the percentage by the zip code. So you can see some of the zip code, they are in much darker color, for example, in the Silver Spring area and the Gaithersburg area. And then the map on the right-hand side is actually for 7-day increase. And you can see they are pretty much actually consistent. And this is also consistent with the pattern we have been seeing. The area with the lower socioeconomic status actually have the bigger increase number and the percentage of the cases. So for hospitalization, that many of you are aware about this CRISP system, that we have been using this system to monitor the hospitalization pattern as well. And the other system we use is the Essence, and then that's the symptom surveillance system that we have been monitoring this system in terms of the hospitalization and ER utilization as well. But because of this emergency preparedness, that we also have been looking for this, the Institute for Emergency Medical Service system. So in this system, you will be able to look at each of the hospital across the entire state of Maryland in terms of the percentage of the usage on their bed, ICU, and then the ventilators. And a couple of examples of the charts that we are looking on this slide. For example, the daily new hospitalization in the state, and then cumulative on a daily basis. And the chart on the right-hand side, the ICU and acute hospital beds use over time as well. And for mortality, recently, we start to receive the line list of the deaths for Montgomery County residents due to the COVID-19. And that's from the Maryland Biostatisticians Administration. And through the case investigation, we also will be able to find out the deaths of the cases as well. And then the other data source, we will get it from the medical examiner. And couple of the example figures over here, for example, the one on the left showing the daily and cumulative deaths due to COVID-19 for Montgomery County residents and also for the state of Maryland. And then the one on the right-hand side shows the case fatality rate over time. So for healthcare capacity forecast, as Dr. Gale mentioned earlier, this is particularly helpful in the very beginning when we know about the pandemic, and then before the surge and the peak of the curve. That there are several models available on the internet that if you Google, you can find it. And then many of the people in this country, they actually look at the model that developed by University of Washington, the Institute for Health Metric and Evaluation. And this model was referenced in the briefing by the White House as well. And this is the model we mainly use, although we do use the information from other models to supplement information as well. The other model is developed by the University of Pennsylvania and the Chan. And we also get assistance and generous support from Dr. Liu and his team who provide the forecast in terms of the cases and the healthcare resource utilization. Just to show quickly one of the example charts that we used previously, and this is based on the University of Washington model. We kind of forecast the number of the hospital bed, ICU unit, and ventilation that will be used during the peak time, almost at the end of April for Montgomery County. And then for the contact tracing, we have been doing the contact tracing, and then recently we step up the pace, try to increase the capacity to do the contact tracing. And the list of items here, those are the data elements that we collect, and then doing the contact tracing. In the local health department, in general, just like us, we are doing the case investigation together with the contact tracing. So when right now we have a school nurses help out on doing the contact tracing, and we also would have some volunteers and students helping out pretty soon as well. And then these are the component of for the data collection that during the contact tracing and the case investigation. So we will collect information on the clinical history, and then the symptom, pre-existing medical condition, and the exposure before and after the onset, and then the contact of the cases with other individuals and the family members. So since the topic of today's presentation is talking about the lesson learned, so this, I think, is the last slide that I have. Is some of the challenges I can think of in regards to the surveillance epidemiology part. So the challenge that we have is on the staff capacity. So in general, for epidemiologists and then the surveillance unit, that you probably don't have so many people sitting around doing the surveillance every day. And then, but for something like this, a pandemic happened, you feel an urgent need that you would need such a big help from so many other people to looking into the data and to consolidate the cases and the deaths, working with the state and other county agencies, and then the hospital, and then try to consolidate all this information. And you also need to develop a centralized and then comprehensive data system in order that you will be able to track these cases and the deaths over time. And then you will have this comprehensive data system. You will also collect information from your contact tracing. And then you will also have data collection from your investigation in the nursing home outbreak and then such. And for the electronic surveillance system, we don't have one particular design for the pandemic like COVID-19, but the NETS has been used across the country because it was designed to for the infectious disease, but it's very antique in a way that you won't be able to connect to all the other systems you are working on. And you need to also manually resolve the cases on a day-to-day basis in order that you'll be able to say, okay, these are the laboratory confirmed cases, and then we are going to make this case into our active case list and such. And then in some of the cases, you may want to flag them as under investigation. And then some of them are disease cases and such. And then I talk about the case investigation and contact tracing. So we have a communicable disease and epidemiology program that we have been working extensively with them doing the investigation and then reaching out to the cases and the family members and the contact for the case investigation and the contact tracing. But when something like this happens, you feel they are short of staff, and then they are very understaffed and in terms of the resource and capacity to respond to something like this. So I think that's the last slide that I have. We can probably open up for questions.
Thank you so much, Dr. Liu. We do have some questions. The very first question was posted from Dr. Franzini. She wanted to know where the data on the number of positive and negative tests came. You had mentioned in your presentation that it came from the State Department of Health.
Yes, so pretty much most of the cases, over 95%, they are from the NET system that I mentioned earlier, and those are all laboratory confirmed cases. And the type of laboratory that use the system include all the public laboratory and then private laboratory.
And the data that are on the coronavirus.maryland.gov, that also lists the number of confirmed cases and the number of negative cases, the most recent data, right?
Right. So both of the positive and negative cases, they can all come from the NET.
Okay, all right. And your next question was, I'm reading it off the chat box here. Does contact tracing include testing of contacts? Does contact tracing include testing of contacts?
So currently, there's a couple ways to answer that. So the first way to answer it is that historically, any individual who's been identified as a contact to a known lab confirmed case, if they have developed or shown symptoms, they have been tested that way through their provider or through another means. Last week, CDC, about a week ago now, CDC adjusted their testing criteria to include a fourth component for individuals who are asymptomatic. And they left that criteria to further define that up to the local health departments and state health departments based upon surveillance data. On last week, I put out a directive to providers across the county that for us, we consider folks of high priority for that group to be any contacts of a lab confirmed COVID-19 case, whether they're demonstrating symptoms or not, and essential employees who are first line responders, including healthcare workers, those in nursing home, long-term care facilities, law enforcement, and other first line responders.
Great, thank you so much, Dr. Gayles. How have you used your environmental health officers and public health nurses to tackle the COVID-19 pandemic locally? That's a question from Dr. Steve Alt.
That's a great question, Dr. Alt. We are fortunate to have a diverse core of folks, as Dr. Liu mentioned. We've utilized our school health nurses, for example, in our contact tracing efforts and the disease control investigation. We've trained over 50 of them to participate in that process. And I think that's another question that popped up in scouting through the chat box. But as far as it relates to our environmental health and nursing home folks, so in Montgomery County, in our health department, environmental health inspectors, as well as our nursing home inspectors, are part of our licensing and regulatory service team, which is a part of public health services. And so we've had both components involved. So from the environmental health side of licensing and regulatory services, they have been instrumental in investigating any complaints related to cleanliness of venues. Also, any complaints related to restaurant services, grocery stores, any of those who are not complying with the governor's directives when it comes to spacing. We've gotten a number of complaints about construction sites. So that team has been investigating and tracking down all of the information relevant to those cases and putting in enforcement to make sure that folks are adhering to the principles and practices that we've put into place, including social distancing, making sure that people have access to face coverings, as well as adequate access to hand hygiene equipment. Particularly in grocery store settings where, our language, before the governor's directive, we actually put in language to require employers to make those provisions to their workers for their safety. The nursing home team has been actively engaged. We are one of the few, I think we're the only jurisdiction in Maryland actually, who do nursing home inspections on a local level. So all of our staff members, the nurses and staff who are part of that team, have relationships and they know our facilities fairly well. And so what we did is back in March, after we had our first 3 cases involving nursing homes, and that increased to, I think over the first week, we saw that increase to 10. And when we noticed that we had a number of facilities involved, we said, hey, we've got to provide an extra layer of support to these facilities. So we created a local version of an action team for nursing homes, and that included recognizing we had these folks in licensing and regulatory services. We took that staff and we trained our disease control nurses and staff, provided a training for them to create this action team. And we did that at the end of March. And it was about a week before the governor put in the state version of that. And it's a little different. So our team is providing mostly virtual support to the facilities. Again, when a case comes into a nursing home, for example, the disease control team initiates that process. They initiate the contact investigation, and they pull in this action team to be able to step in and provide additional support in terms of infection control guidance, making sure that they, if they need personal protective equipment, that those types of things are put into place. And as the directives have increased in terms of expectations, such as the use of PPE with all patients, cohorting of patients who've tested positive in certain spaces, they have been playing a role to make sure that the facilities are adhering to that. And if further actions need to be taken and escalated, whether that's through a health officer's directive to them to get things together, or involvement of the state on any level in terms of coming in and doing an in-site site visit.
Thank you very much, Dr. Gayles. As you can imagine, we've got lots of questions and I'm trying to help you stay on top of the questions. So please let us know if you need a break. One of the questions that came across is, does Maryland have a standard definition for recovered cases? Recovered cases.
Well, I think the definition, and this is a little bit tricky because when you look at the information, you look at the state website, for example, you'll see a larger number, but then it varies by jurisdiction. So it makes it look like, for example, I think Montgomery County still only listed as 3 recovered folks versus, several hundred somewhere else. So a lot of this is dependent upon, the CDC criteria for clearance of the virus. So in the beginning, what the measure that was used is you had to have 2 negative tests within a 24-hour period to be officially deemed cleared of the virus. Now, over time, that has changed to, it went to, yes, that it remains a criteria, but then there's also an alternative category that says that if you, 7 days from the onset of symptoms, at a minimum 7 days from the onset of symptoms, and you have had 3 consecutive days of no symptoms, including no fever or any other COVID-related symptoms, you were considered to be, cleared of the virus and can return to work. Now that has changed a little bit. For example, they introduced a category for asymptomatic individuals who've tested positive as well. And originally that guidance was if you've continued to be asymptomatic from 7 days from when you've tested positive, you can return to work. They've now adjusted that over the last week to say 10 days from your test date, as long as you've continued to stay asymptomatic during that process. So I say all of that to say that The definitions for clearance have been based upon the CDC guidance, and that has evolved over time as more information has come in.
So is that 10 days after testing and no symptoms?
Yes, that's correct. If you're an asymptomatic individual who, for whatever reason, I can think of one example. There was an individual who happened to, was identified as a contact for a lab confirmed case, happened to get tested, tested positive, but just continued to have no symptoms. Reviewing through, the guidance was 10 days after your positive test. They continued to be asymptomatic, and the consensus was that they were cleared to return to work.
Thank you so much, Dr. Gale. I am jumping ahead to make sure that I ask at least one question for each person who's posted. Some people have posted more than one, so we may be going back to a few of the topics that we touched earlier. The next one is from Dr. Dushanka Kleiman. She wants to know, once contact tracing is completed for a given case, do you have a systematic way to go back to the contacts?
That's an excellent question. We're still figuring that out. One of the challenges of this, and I pulled this in not to make any excuses for what we're doing, but it's been an interesting conversation. As you mentioned, my former life before coming to Montgomery County, I was in the DC Department of Health overseeing the sexual health program there. And for a number of years, our budgets in sexual health were cut significantly. Our DIS, disease intervention specialists, who do a lot of the contact tracing historically, in many cases were cut. And so a lot of local health departments lost the capacity of those with expertise in understanding how to do contact tracing over time. And so as this process has started, many of those health departments have been hamstrung in terms of being able to do that. So what we have done is, as this evolves and we start to utilize some of the electronic platforms, I think this was another question that popped up in the chat room. We're exploring those different options. We are looking at outside vendors to be able to help with that, as well as continuing conversations with the state, who is working through NROC, to be able to provide some assistance in that and standing up a statewide contact tracing response to be able to help all of the health departments in a coordinated manner. And part of those efforts are going to be ongoing conversations as to how to look back to previous cases. Right now, I think that everyone's trying to get that initial contact as quickly as possible. And again, hopefully utilize and leverage these electronic platforms that make it easier to be able to reference. It's like, oh yeah, Olivia, you had a test 2 months ago, and I'm coming up, I see somebody else in your network now. How does that trace, does that trace back to an exposure 2 months ago? Or is this a new setting, and how do we go about doing that? I'd love to say we figured that out. We haven't, but we are actively engaged in trying to work through those issues to be able to provide a more timely response in terms of creating a profile of what the disease looks like in the county.
Thank you so much. Sonika had a question. She says she's a doctoral student in our department. She's been volunteering with the health department for contact tracing, and over the time, she's interviewed several cases who are not comfortable with sharing their employment, even after assuring them that their identity will be kept confidential. And this makes it very difficult to trace the contacts in the workplace of such cases. And and also to understand to what extent they have spread the virus. So she has two questions. Her first is, as a contact tracer, what other information can be focused on collecting from the case that might help to tackle this issue? And second, how is the Department of Health tackling this issue? And she's not the only one. We also have other students who have volunteered to serve as contact tracers.
Sure, I think part of what she mentions is, and this gets to some of those cultural dynamics that aren't specific to COVID-19. There is historical mistrust in terms of, think about it. You've tested positive for a disease, and now you have somebody calling from, you perceive them to be calling from the government. What does that look like when I'm asking you in-depth invasive questions? So part of what we're looking at now is, given that those efforts are increasing, we recognize that we have to do a better job and a more intensive job in terms of providing that upfront education so that we can prep people to say, hey, you may receive, if you test positive, you will likely receive a call from someone. This is the purpose of that call. This is why we're asking these questions, so that the first time they get that call isn't the first time that they're hearing that. And so that's something that we're trying to figure out how to better do, particularly as we test more people and that becomes more of a reality, so that when we do call them, that they may understand better why we're asking the information and how that information will be used.
Yeah, so I do want to add a little bit about this contact tracing. So we have a training program, orientation that for the contact tracer and then case investigation. And but some of the volunteer or the staff who start to do the contact tracing, after several days, that we feel some of them may not be appropriate candidate to do the job, and because it requires some personal characteristic in order to complete the collection of all those data and then talking to the cases and such. But this is just something I want to add.
Thank you so much. One of the clarifications that was requested by one of our participants, they wanted to find out which of the protocols for contact tracing is being used. Is it one provided by the state of Maryland, CDC, or another source?
So we do have that. We actually kind of look at several of the sources and then develop a more comprehensive contact tracing the training package, and then we have been using it, but we keep updating and revising accordingly as well as there is a new guideline developed.
Thank you so much. Any gaps in being able to provide public health messaging in different languages which are used in public health communications? Any gaps?
The short answer is yes. The long answer is yes. I think, any of us, again, in public health know that, communication is an issue, that predated us in COVID. And what's been a challenge is having to be able to turn information around very quickly and make sure that not only is it available in different languages, but it's also passed along in a way that addresses literacy issues and understanding from a health literacy perspective. I think of one example, and I'm not shifting away from language. So yes, we have gaps and we need to do better. That's it. And I know the communications team here has employed a lot of different strategies to help improve with utilizing different resources to translate documents and do live interpretation of settings. We've done a couple of town halls with in time, real-time translation. I'm pretty sure the county executive is doing one tonight, a virtual town hall in Spanish. But one of the things that jumps out is when we had over Easter, the Easter holiday, when people were putting out messages. The messages: "Stay home, stay home, stay home." But we recognize that people are going to go because it's a holiday. They have traditions. They spend time together, and so instead of just emphasizing the stay home message, we thought of we talked about how you can translate that into a meaningful way that's relevant to their folks' realities. So saying, hey, we recognize this is a holiday. You traditionally probably go get together with family, you have dinners, you do those kind of things. So, but this year we're asking you to stay at home, and think about other ways that you can still do that activity, just potentially through a virtual space that is respective of physical distancing and that kind of stuff. So yes, we've got a long way to go. I can't think of any health department that has perfected the art of it, and so we continue to try to get better.
Thank you so much, Dr. Gayles. In preparation for my webinar that I gave on Monday, I did compile a list of Spanish language resources in regards to COVID. And so it's available on our website and includes the University of Maryland Extension Service, what they've done to compile that information, as well as the Latino Health Initiative Facebook page. to get the word out. And that was bringing in resources from colleagues from across the country. So that hopefully by working together, we'll continue to amplify what's being disseminated. Had another question that came up. How has the pandemic response required your department to adjust your annual program budget, or borrow funds, or apply quickly for grants? I know this was not on your radar screen even 6 months ago.
I guess I'll take that question. It's such a pleasure. We'll say this. So it's not been on everybody's radar. You're right. I don't think any of us anticipated this, and even as a couple months ago. So there's diversity in funds in terms of how that comes in. So we, fortunately, in many instances, a lot of, at least, the state grant funds are held constant and are being moved forward because work does continue that's non-COVID related. I think, there's been a number of other resources. So, for example, there's funding from the CARES Act legislation that was passed by the federal government in terms of providing additional assistance to jurisdictions to keep the doors open, as well as be able to respond to COVID-related things. And pretty sure each jurisdiction got some of that. We got a good portion, and we are looking at how we can leverage and spend those resources, again, to maintain the services that we provide on a regular basis, but also provide additional support in spaces that need the funding to do so. Fortunate to be in a jurisdiction and a state that has prioritized and said, the resources we need to fight this, we will work to make sure that you have them at your disposal. And that's very meaningful because, as we, for example, when we talk about expanding testing capacity, you've got to have money to buy these things, and you've got to have money to buy machines, and you've got to be able to, particularly when you are mandating and asking people to do something, you also have the responsibility to be able to provide the support to help them do it. So I say all that to say that we've had to be creative, but as for the local as well as the state level, the resources we've needed have been provided.
Thank you so much. Looks like another question popped up. Has your department been in contact with other county health departments like Public Works or Water and Sewage, Solid Waste, in order to orient them on how to protect their workers?
Yes. So this actually speaks to some of the behind the scenes stuff that we do. So again, a special thank you to all of the different government agencies within Montgomery County. So before we got our first cases on March 5th, again, that date will be forever etched in our minds, March 5th, 2020. Several weeks before that, we engaged the department heads of other county agencies and pretty much came up with homework assignments for each of them to think through in terms of their work policies, their strategies, what their contribution would be to a COVID-19 management system. And so those agencies started working on those policies in advance. And over time, we worked closely with a combination of our Human Resources Department, our Office of Occupational Medical Services, as well as we've had union engagement involvement in that process to make sure that all of the policies, whether we're talking about our first line responders, front-facing staff, have the necessary precautions in place to make sure that it's safe for them to work and execute their jobs.
Thank you. And I'd like to ask a question to both of you. It's hard to believe you mentioned March the 5th. Today is May the 6th. We've only at this for, what, 2 months? It just feels like a lifetime has passed. Any tips, any suggestions that you have? We have many students who are on here, sort of lessons learned, things that you're really glad that you had the experience and the training to get you prepared to deal with this crisis. Any tips that you would like to give our students?
I'll let Dr. Liu go first, and I'll close it out. I'll let, to break up the monotony.
So yeah, so some of you may know that my training is actually not in infectious disease epidemiology. So I was trained in occupational environmental epidemiology. So although infectious disease epidemiology is not new to me as well, I've been working with it, and but something to this extent actually is totally new to me. So I have been providing support, to the health department on this particular situation, since like February, March, and until now. Although it's like 2 months, but it feels like forever. And but it kind of, because of this, it kind of bring back everything that you learn in the school about, okay, your disease surveillance skill, and then your knowledge about epidemiology that you learn, what you should be looking at, and you look at a trend over time, you look at the health disparity by population subgroup and all these things. So it's a little bit like a combination of all small pieces all together. They all get to be used in the same situation. But I think this is also a good opportunity. If you never go through this kind of experience, you will never know like what you will get to experience. But this is good, because the next time, as Dr. Gale mentioned, there is like a COVID-23 or something, that we are much in better shape to get ready. And the first thing I would say is probably to set up something as a comprehensive database to collect all the information and then try to take it from there.
Dr. Gale, what would your tips be for our students? Things training that you're glad you have, and, getting yourself prepared for this point.
Well, I pull on from different experiences. So first, from being a clinician, the thing that has kept me is keeping your wits about you and staying calm in a setting, even when there is chaos and there's high adrenaline. I liken it to, when you've got a patient who's coding and they're looking to you as the attending, you don't have time to panic. It's time to execute. And part of that is trusting in your skill sets, trusting in your training, and relying on that, not being overconfident, but being confident that applying what you've learned. Because the reality is, as Dr. Liu mentioned, no one has a playbook for COVID-19. None of us have ever experienced this. Even the more senior folks in the crowd, none of us have done this before. And so you have to, still yourself and trust in the tools and techniques that you've learned to move forward. I think from divorcing from all of the background noise, so to speak, this really is a fascinating, and I don't want to trivialize the impact of any of this, but it really is a fascinating experience to put into play all of the different things we learn from a surveillance perspective, a policy perspective, a health communications perspective, to throw everything that we've got to fight this and figure out how to get to the other side. And something very valuable that a professor of mine told me when I was an undergrad, I don't know if any of you used to read the Washington Post. Professor Bill Raspberry, he used to write articles. He's Pulitzer Prize winner who wrote articles, op-eds in the Washington Post for years. And I took a class with him, and everyone was, like, you're Bill Raspberry, you're greatest. We don't want to say anything because everything you say is expert and wonderful. But he told us flat out, he's like, I'm teaching this class, and yes, I have my lived experience, but you bring to the table X amount of years of expertise because you're the one who's had your lived experience, and it's important for you to speak up and contribute. And I think it's easy in these situations to sometimes defer to those who are experts, but as we've talked about, none of us are expert in this. And so all of us have something to contribute. So don't be shy, raise your hand, get into the game, put forth your expertise and put forth the great stuff that you've learned through the University of Maryland. You've got lots to contribute.
That sounds like a wonderful way to wrap up this webinar. Thank you so much for your time. Dr. Liu, I know he's very excited to be able to come and talk to us about modeling on Friday. I hope you'll be able to participate or at least join some others to join in the dialogue. Anything else you want to say, Dr. Liu? Our Dr. Liu for the Department of Epidemiology and Biostatistics.
Hello, this is Hongjie Liu, the chair for the Department of Epidemiology and Biostatistics. I want to mention this. Both Dr. Gayles and Liu are also adjunct faculty in our department. And we sent numerous students to their departments for internship. It is also my honor to hear the first-hand experience from the front line of the epidemic of COVID-19. Thank you too very much. And also, stay safe.